Muito obrigado, Vivian, Esper, por la invitación a falar a gente, mas vou falar in inglês. This is an update on pre-exposure prophylaxis. I'd like to review where we are from a clinical and clinical research point of view. Much of the data is in at this point. The data from the phase 3 clinical trials is mostly in. And this has led to interim guidance from the Centers for Disease Control in the United States related to pre-exposure prophylaxis for men who have sex with men. The co-formulated drug containing emtricitabine and tenofovir has been approved for PrEP, or pre-exposure prophylaxis, by the U.S. Food and Drug Administration. The Centers for Disease Control last July issued guidance on pre-exposure oral prophylaxis, or PrEP, for serodiscordant couples, men and transgender women who have sex with men, and others who are high risk for HIV. The WHO guidance emphasized that the evidence for use of PrEP in MSM and discordant couples was high quality, but that demonstration projects were needed to optimize delivery of this new concept and to optimize the monitoring. So from a clinical point of view, I thought we should just spend a moment on how to use PrEP. I mean, what are we thinking about how to actually do it from a practical point of view? I gather that some of you are physicians or nurse practitioners, people who are in a position to consider prescribing PrEP for some of your clients. This is the guidance provided by the Centers for Disease Control. There will be guidance issued from other regulatory agencies as well. The idea is to consider PrEP in HIV uninfected, men who have sex with men, discordant couples, or really anyone with a sexually transmitted infection, including gonorrhea, a new diagnosis of herpes or syphilis. Such infections are de facto evidence of high risk for HIV. In addition, we know that the benefits of PrEP mainly occur in people who are not using condoms consistently. This is also a robust indicator of high risk of acquiring HIV. Importantly, it's important to test for HIV before starting. Really the only risk of drug resistance that we have identified so far is in people who are already infected with HIV at the time they start PrEP. Rapid antibody tests are the most convenient because they're done at the point of care, and the person prescribing PrEP can know the results of the test at the time that they're prescribing. Laboratory-based assays can be more sensitive, especially if they detect antigen or RNA, but this can create a lag time between the test result and the prescription for PrEP. You want to minimize that lag time. So point-of-care antibody testing is the most convenient way forward. These drugs are active against hepatitis B, and they're actually considered good therapy for hepatitis B. But hepatitis B is a complex chronic infection to treat, and the issues are different than the issues related to PrEP. If you have someone who is hepatitis B infected, you have to consider whether or not you're going to monitor hepatitis B viral load. You also have to consider the risk of hepatitis flare every time the person stops PrEP. So hepatitis B is a special circumstance. PrEP can still be used, but it is complicated by the fact that you're treating a chronic infection as well as preventing a second chronic infection. Hepatitis B, fortunately, is very easy to prevent with a widely available vaccine. The vaccine is underutilized, and I think that those of us who are interested in developing vaccines need to appreciate the fact that even in a country like Brazil or South Africa or Thailand, where there have been recommendations to use hepatitis B vaccines for men who have sex with men, only 30% of those who presented for IPREX had any evidence of prior vaccination. So when we have a vaccine, we do not typically use it, at least not in adults, indicating that we have other challenges in public health. The prescription for PrEP should be daily. Daily dosing does allow for routinization. It also allows for achievement of very high drug levels in the body, such that there is forgiveness for missed doses. Both the CDC, WHO, and FDA ended up recommended daily dosing, even though people may be able to get by with less, and I'll show you that data later. Interactive client-centered support for adherence is important. It does not have to take a long time. In fact, brief counseling support is probably better than long duration. Asking about adherence, helping people solve problems with adherence are the ways known to work. Finally, monitoring during PrEP use, monitoring HIV and serum creatinine every 3 months is recommended. Other safety monitoring is not regarded to be essential for the use of PrEP. We're really talking about just 2 tests, HIV and serum creatinine. So what are the questions about PrEP that that have come up that are in some ways limiting its use and that you should know about? The questions are, is it protective enough to actually be useful in practice? Is daily adherence or something close to daily adherence even feasible for people? Will drug resistance occur rampantly? Is prevention futile? We think that some of the hesitancy to implement PrEP is the notion that if you're not perfectly adherent all the time, the moment you slip up, just like with a condom, infection will occur. And we have data on that now, which I'll share with you. Will people using PrEP have riskier sex that could offset the biological benefits of the approach? And finally, will PrEP programs interfere with treatment initiatives, which are also known to decrease transmission? So the first question is, does PrEP work well enough to be used in practice? This is a slide summarizing the current data available from randomized and placebo-controlled clinical trials, looking at efficacy of oral co-formulated emtricitabine tenofovir PrEP, analyzed on an intention to treat basis. And so this includes people who were offered PrEP but chose not to take it. You can see here that efficacy in the 2 pivotal trials that were considered by the FDA, IPREX and Partners PrEP, ranged between 42% to 84%, depending on the group. The TDF2 study done in Botswana and sponsored by the CDC also showed strong evidence of efficacy that was statistically significant. 2 trials, importantly, and I'll talk about them, FemPrep and Voice, showed no evidence of efficacy in young African women. So the clinical trials have shown mixed results. The one trial done in men showed robust evidence of efficacy, but the efficacy estimate on an intention to treat basis of 42% was relatively modest. So I think it's important for us to consider what is included in an intention to treat analysis. It is an analysis that is strictly from the investigator's perspective. And so you can imagine the investigator, here my first mentor, Merle Sandy, looking through binoculars at a distant population of potential PrEP users who are randomized into your trial. And the only thing he's really caring about in the analysis, the only thing he includes in the analysis, is what drug, whether it was drug or placebo, was offered to the person. How they actually used it is not considered in the intention to treat analysis. So this analysis includes all of those who were offered PrEP, even those who chose not to take any of it, those who took some and then gave it up, those who left the study and then return, quite possibly because they already know they're HIV infected and they want clinical services that the study is offering. Those people are also included in this analysis. And absolutely no information about how PrEP is taken is considered in the intention to treat. So these are all factors that need to be considered when interpreting an efficacy estimate of something like 44% for IPREX. We have an ability to measure drug in blood. These drugs have long intracellular half-lives, so we can detect even 1 or 2 pills taken per week as detectable drug in the blood. And you can see here that there's a close concordance between the efficacy measured on an intention to treat basis and the percentage of the cohort that had detectable drug. In Partners PrEP, 81% had detectable drug, efficacy was 74%, 75%. In IPREX, for example, only 45 to 51% had detectable drug, and our efficacy was 44%. In studies like FemPrep and Voice, drug exposure was so small, less than 30%, that efficacy could not be evaluated. So what about other kinds of analyses? Sometimes these are called as-treated analysis or explanatory analysis. The idea of these alternative analyses are to try to understand what is happening at a biological level. What happens if you actually use PrEP? And these kinds of analyses consider only people taking PrEP while they are taking the drug. And we try to use our best indicators of drug use, which at this time are direct measurements of the drug in the blood, typically using tandem mass spectroscopy. And to be sure, these kinds of analyses are not primary. The primary analysis can and should be the intention to treat, because that's the least biased estimate of whether or not this thing works. And we'll talk about why. But the importance of as-treated analysis, I think, is embedded in the way we consent people. And this is the consent we used for the IPREX study. When we told people why this study was being done, we said it is also designed to see if Truvada, or FTC-TDF, once a day can prevent acquisition of HIV infection while people are taking it. So it says to see if taking Truvada decreased HIV risk. So in fact, we consented people to the as-treated analysis, not to the intention to treat. This is common. I think if our participants actually knew how focused we are only on our own intention to treat, they would learn something about the way we do clinical science and their role in it. So what do we know about drug concentrations in the IPREX study? On the right-hand panel, we see a random sample of seronegative controls and seroconverting cases. And compared to that is, you could think of it as a standard curve from a separate study called STRAND, in which we gave directly observed therapy of 2 pills per week, 4 pills per week, or 7 pills per week. And you can see the kinds of drug concentrations we would expect to see in the blood associated with those different dosing patterns. Several important features need to be pointed out. One is that among the seronegative controls who were protected in IPREX, the average drug level was commensurate with somewhere between 2 and 4 pills per week. So protective levels of drug did not require daily dosing, but rather something less than that, 2 to 4 pills per week. The other point is that the vast majority of people who became infected in IPREX, of the 42 infections in the cases, only 3 out of 42 had any detectable drug at all, and none of them had drug commensurate with 4 or more pills per week. So to date, we have yet to see in any of our trials of gay men anyone becoming infected during PrEP use with drug levels of 4 or more pills per week, or drug levels commensurate with 4 or more pills per week. And so this is the regression analysis that comes from that data. And you can see here that even at relatively low concentrations of tenofovir diphosphate on the x-axis, we see substantial reductions in HIV risk given by the blue line, whereas the incidence in the placebo arm is given in the black. And so the curve, the dose-response curve is steep. Even a little bit of this drug was enough to provide high levels of protection. These bars indicate the concentrations of drug achieved with 2 pills per week, 4 pills per week, and 7 pills per week. You can see that the level of protection was substantial even with 2 pills per week. 4 and 7 pills per week are associated with high levels of protection. There's additional evidence that seroconversion happens during attempted PrEP use in the absence of any virologically important level of drug. As we've discussed, there's among PrEP seroconverters in IPREX, the drug concentrations were either absent entirely or were low. But in addition, we know that those becoming infected during attempted PrEP use had comparable viral loads compared to those becoming infected in placebo. If we know anything about these drugs, it's they suppress viral load, and when present, they suppress viral load by about 100-fold. So the lack of drug viral suppression is indicative that whatever drug may have been present was virologically negligible. In addition, there was no evidence of drug resistance, and we know that FTC, if present, readily selects for a drug resistance mutation at the 184 codon of reverse transcriptase. And this is the data regarding drug resistance. Again, I'm using it to show evidence that PrEP fails really in the absence of virologically important levels of drug. We can measure them directly, but this is a virological measure of drug exposure. And you can see here on the right-hand side, among those uninfected at baseline in 4 published studies at this time, IPREX, Partners PrEP, TDF2, and FemPrep, that levels of 184V-mediated resistance to FTC or lamivudine are occurring at about the level that we would expect from primary or transmitted resistance. Now, the risk of FTC resistance is greater if people have acute HIV infection before they start PrEP. This is indicated on the left-hand columns, indicating that something like 60% of those who are acutely infected when they start PrEP, that is, they have viral RNA but antibody negative, about 60% of them will end up with a 184 mutation. Fortunately, these mutations, these acute infections can be detected either with antigen testing done in a laboratory, unfortunately not by the rapid antigen test, or acute infection can be readily detected by viral RNA testing. In addition, individuals who acquire 184V-mediated resistance after starting PrEP with acute infection will see that resistance wane to low levels of the virus population within 6 months. But I think in public health we have to weigh risks and benefits, these data indicate that PrEP programs, as implemented in these trials, some of which failed, some of which succeeded, prevented 15 HIV infections for every case of 184V that may have been selected because of use of PrEP in acute infection. So the benefit to harm ratio is substantial in favor of PrEP implementation. So this is just a summary of how well PrEP worked when it was actually taken. The risk reduction was 76% associated with 2 pills per week. 96% when drug levels were commensurate with 4 pills per week, and 99% when drug concentrations were commensurate with 7 pills per week. This is a as-treated analysis, but I propose that this is the most relevant to clinical decision-making and to helping your clients and patients decide whether PrEP is right for them. They either know or will know whether they will take it 4 times a week or 7 days a week. These are the benefits that they can expect with that pattern of use. Now, the reason that we don't make more of the as-treated analysis is a problem of confounding. And I think it's important that we understand this and talk about it explicitly. The idea that there is a problem or a potential problem with confounding whenever we consider a correlate of protection in our studies, whether it's a vaccine study or a PrEP study. And the question is, what is the cause of the association between the indicator, be it an immune response or a drug detection or something else, and lower HIV risk? And so you can see, as I've just shown you, strong associations between indicators and protection measured as HIV risk reduction. The concern about this kind of analysis that does not apply to intention to treat is that there can be confounding. So there can be other factors that you're not measuring that may be strongly associated with your indicator and also strongly associated with protection. And so it's not the presence of the indicator that causes protection, but rather the fact that it's just showing you about something else that you haven't really measured. And so it is possible for there to be no association between the indicator and protection if confounding is present. Well, let me give you an example of where we've seen this happen. In the VaxGen trial, there was no efficacy of the vaccine on an intention to treat basis. But initially, with the initial reports, there was much made of this association. The fact that those who had antibody binding to GP120 or CD4 had lower HIV risk. And this was seen, this is on the x-axis, the quartile of antibody binding strength versus HIV incidence. And so what this suggested to some people was the possibility that the vaccine could work for a subgroup of people who are responsive to it immunologically, and that that could still be a win if there was enough people who were, for whom it was immunogenic. But the problem here is bias, and this was addressed in a subsequent paper in which they plotted those same risk reduction curves against the incidence of HIV in the placebo arm. And this is now shown here in the black line, and HIV incidence is plotted here relative to incidence in the placebo. And when this correlative protection was analyzed in this way, you can see that having an immune response was never better than being in the placebo arm, really showing in a more definitive way that the association between immune responses to the vaccine and risk reduction was confounded by some biological factor yet to be identified. So, but remember this, when you see confounding in the analysis of indicators and outcomes, that confounding will look like this, where the risk is actually higher in those without the indicator, and it goes just to placebo levels in the presence of the indicator. Is this what we see in IPREX? No. Those with no detectable drug, indicated as BOQ on the left, actually had incidence of HIV that was 18% less than placebo. So there was no crossing of the curve relative to placebo, and this turns out to be the strongest, most robust evidence that confounding is not driving the drug protection relationships observed in the PrEP studies. So the other way to address the possibility of confounding is to really think through what are we concerned about. And in the case of PrEP, we're concerned that adherence to the drug and adherence to other safer sex methods may occur in the same people. Those who take the drug may be the very same people who use condoms more frequently or who talk about HIV status with their partners more effectively. And so we are concerned about that safer behavior or more organized lifestyles may explain some of the observed association between drug detection and protection. But in fact, we do not see these associations. If anything, people who are riskier were more likely to take PrEP. So the the association would only work, the confounding would only be present if the drug takers or the adherent people were also safer from a sexual point of view. In fact, we see the opposite. Here, among those reporting unprotected receptive anal intercourse, drug detection was 54%. Those having anal intercourse but using condoms consistently, drug detection was 42%. Those having no sex at all had 38% drug detection. So the association goes the wrong way. In fact, people who are using condoms less are using PrEP more, and so safer behavior cannot explain the association between drug detection and HIV risk. And we also saw this in our intention to treat analysis of subgroups. In fact, we see in this last block that the PrEP benefits were almost entirely observed among those reporting less consistent condom use. Again, this argues against confounding as an explanation for why PrEP was virtually 100% effective among those who took it. So in fact, we do believe that the evidence is robust that taking the drug, taking PrEP, is associated with 99% reduction in HIV risk or more if drug concentrations indicate daily use. So the next question that comes up is whether daily use is even possible for people. We know that people are imperfect. But I would point out that daily adherence is achieved, or some approximation of daily adherence is achieved for prevention in several circumstances. We use antihypertensives to prevent atherosclerosis. These are very effective. We use cholesterol-lowering agents also to prevent atherosclerosis, including strokes and heart attacks. This is also effective. Aspirin, taken daily, prevents blood clots. Contraception has been used effectively for 5 decades at this time. However, we also have to be aware that oral dosing is less easy to adhere to than injectables. And we can see this with pregnancy rates, where among couples not using any contraception, conception rates are about 85% per year. This decreases tenfold to 8% if oral contraception is used, requiring daily pill taking. But the risk of conception decreases still further to 0.4% if an injectable or implantable contraceptive device is used. So I think that oral dosing for prevention is clearly feasible, but imperfect. Common features of preventive agents that work when taken daily is that there has to be forgiveness for missed doses, or at least a few missed doses. And it helps if there's biomarkers, such as blood pressure, cholesterol levels, or menses, that help people and give people positive and negative reinforcement when they're having difficulty taking the preventive agent. Whether drug levels, in the case of PrEP, will emerge as the way to monitor and guide PrEP adherence interventions is a topic that's being addressed currently in trials. But I think that importantly, when asked, is it feasible to take this daily, we need to look to the US population. And here we can see that PrEP trial participants in IPREX, and the same was true for the safety study done of tenofovir PrEP in the United States, that drug detection rates were well over 90%. In fact, they were 94 to 100% in those two trials. So PrEP with either tenofovir or emtricitabine and tenofovir can be taken, and effective concentrations can be achieved by the vast majority of users if the social circumstance is right. And at least we got that social circumstance right in the United States. Whether that can be achieved in all places around the world remains to be seen. And that is, in fact, why the WHO recommended demonstration projects to look exactly at that question. What are the social circumstances required for people to actually do PrEP? But this data is sufficient to tell us that it's possible. When people in places like the United States, where people are actually using PrEP, do we see high levels of protection? Well, we think we do. The modeling estimates that include our measured 92% reduction in HIV risk associated with any detectable drug, and our 94% drug detection in the US corresponds to an estimated efficacy in practice in places like the US of 86%. Have we seen anything like that? Well, in fact, we have. When you compile data across the two studies done of PrEP in the United States, we see that there's been 9 seroconversions, all of them occurring off PrEP. So we have yet to see PrEP fail in the United States. However, in other circumstances, adherence to PrEP, even in the context of a clinical trial, can be quite low. The latest example of this was the VOICE trial presented by Jeannie Marasso at the CROI meeting in Atlanta. In that trial, young women in Africa randomized to receive daily emtricitabine tenofovir or daily tenofovir alone, or a daily tenofovir vaginal gel, only had drug levels associated with any use at all in 20% by the end of the study. So only 1 in 5 used any of these interventions at all by the end of the study. So use of this drug, and here I'm not talking about adherence. Adherence might be, the proportion of daily pills that were taken. For someone to have an undetectable drug level in these trials, they would have had to take no drug in the last week, and probably none in the last month. So why is adherence so low in prevention trials in young people in some places? Well, I think that we need to realize that there are several factors going on in these trials. First of all, men and women are being randomized to something that might be a placebo. And the point of taking a pill that might be a placebo is only going to be understood by people who are true believers in research. We think that you can become a true believer in research, but it takes some favorable history, some favorable experience, maybe some background. This is not present in every place of the world. And I'll just tell you an anecdote At many of our study sites around the world in IPREX, we found that people tried to hide the fact that they were participating in trials. In fact, they were embarrassed if their family or their friends discovered that they had signed up for a trial that included a placebo. Some of them were criticized. Some parents were angry to find their young boys involved. It's a completely different experience in the US. In San Francisco, there were times when I felt like I couldn't buy a coffee on the street corner without running into a participant in one of our trials. And they were proud to be participating in those trials. They said, you know, I'm doing this thing, and I'm going to see if it works, and my friends are going to love it. And it's a very different attitude. And I think it's because the trials that showed that antiretroviral therapy were done mainly in the US and Europe. And people have seen very directly in their own life and the lives of their friends how those trials have made an enormous difference. They've saved lives. They've allowed us to eschew or not use treatments that we know fail. Those studies are sometimes the most important. There was a time in the late 80s, early 90s when we hoped that 1 or 2 nucleoside analogs was enough to save people's lives. And folks on the streets trying to use it were saying, you know, it doesn't feel that way to us. It feels like maybe we're getting 1 or 2 years of benefit from 1 or 2 nukes, but it's, you know, after that, it just feels like I'm sick again. And the Concord trial, with its unexpected result that monotherapy only prolonged life by 1 year and then had no durable benefit beyond that, was an eye-opener. It allowed people to say, that is not good therapy, move on. And it paved the way for 3-drug regimens. So folks who've had a chance to live and learn from clinical trials and see the enormous impact that it can have, I think are true believers in why you might sometimes be involved in a study that involves a placebo. If you and your participants have not had that experience, then it's going to seem pretty ridiculous to take a pill that might be a placebo. In addition, these trials are hyper-vigilant about safety concerns, and unfortunately, our consent had 18 pages. 7 of those pages listed possible side effects. Not a single one we actually observed in any of our studies. And yet our sponsor and others felt it very important that we warn people of every possible thing that might go wrong while telling them that there's no known benefit of anything that they're doing. So under that circumstance, should we be surprised when people opt out, join the study, but then decide that they'll wait to take the pill when we know more? There's also money and gifts for visit adherence, but no incentives for actual use of the product. This is less of a concern in Brazil, where such incentives for adherence are minimized. So moving along, I think that underlying some of our concern about all prevention modalities is this concern about prevention futility, which I would define as interventions like PrEP will eventually fail if they do not have a durable impact on the conditions that allow transmission. And so there can be biological prevention futility, which would occur if PrEP suppresses seroconversion but doesn't actually prevent infection. It just delays our ability to observe it. Could be behavioral futility if people at risk are always at risk, and during periods of PrEP use, their infections are delayed only to occur during the first lapse in use. There's also a statistical version of prevention futility, and that idea is that if PrEP is not actually 100% effective, if it's only 99% effective, and people have hundreds of potential exposures, the cumulative risk of HIV will continue to grow in massively exposed people who are then eventually become infected. So we now have data to address this concern of prevention futility. By the way, this is a new concept. You're not going to find it in textbooks. We're just starting to talk about it now. But we do think that it is a lingering concern in many people's minds. So what are the predictions of prevention futility if it's actually occurring? One is that infections averted during PrEP use would occur rapidly after stopping PrEP, and that there would be higher incidence after stopping active PrEP versus after stopping placebo. So in the IPREX study, we had a chance to test whether or not prevention futility was actually occurring. We did this by comparing the HIV incidence during the randomized phase of the study and then during an approximately 1-year gap after the randomized study was finished and before the start of the open label extension. And you can see that the cohort continued to be at high risk of acquiring HIV. having an incidence of 3.9% in the placebo arm during the randomized phase and 4.1% in that same group followed afterwards. There was no excess in HIV incidence in those previously protected by PrEP use. Again, the incidence was 3.1% among those offered PrEP but who didn't use it, and the incidence was 0.3%, or extremely low, among those who actually used PrEP. But importantly, during the gap, after PrEP had to be withdrawn because it wasn't yet available in clinical practice, their incidence was 3.3%. If prevention futility were occurring, the incidence would be much higher than in placebo. In fact, we see a trend toward the opposite. Why is this occurring? Well, we now realize that exposure or potential exposure to HIV is intermittent. And so the premise that people who are exposed to HIV are constantly and massively exposed is not really something that we observe. And in fact, in this graph, we see all of our seroconverters, and the dark orange is quarters or 3-month periods in which unprotected anal intercourse was reported. Yellow is periods of safer behavior, and you can see that virtually all of them go in and out of periods of potential exposure to HIV. So what about concerns about whether PrEP is going to cause people to go crazy and have lots of partners and stop using condoms? In fact, we do not see this in our trials, neither in IPREX nor in Partners PrEP. Such self-reported data could be biased. So we looked at acute infection prevalence and found that the prevalence of acute infection also decreases in the placebo arm by 3.8-fold and in the active arm by 6.5-fold. So in this objective indicator of acute infection rates, we also see that the whole cohort got safer over time, even though they were offered PrEP. And I think we need to consider the theory of risk compensation. And when we review all of the available data, we see that in fact when people are offered a biomedical prevention intervention, like a vaccine, like circumcision, like PEP, or like PrEP, their behavior becomes safer. And we've seen this in 4 PrEP trials, in 2 PEP trials, during treatment rollout, and during circumcision trials. So a variety of blinded and unblinded studies have all shown the same pattern towards safer behavior among those offered these supposedly moral hazardous interventions. There's only been 2 studies which showed any evidence of risk compensation at all. One was a vaccine trial of 48 people, so very small. And in fact, they didn't really see an increase in risky behavior. What happened was that insertive anal intercourse increased and receptive anal intercourse decreased. This occurred during a time when strategic positioning was being advocated by pioneers in Sydney. So it looked like people were just doing what they were hearing worked. There was a condom community intervention which showed an increase in numbers of partners, but the increase in numbers of partners was 0.3. So it wasn't exactly going crazy. It wasn't really an orgy. What it was young people going from having no partners to having one partner when they were offered the possibility of using condoms. So I think the specter or the fear of risk compensation is overblown. So why does behavior actually become safer in most of our trials? Well, we know from qualitative research that there's less denial of HIV, paralyzing fear is replaced by action, pills also can serve as a daily reminder of imminent risk, and taking PrEP allows that risk mitigation strategies be thought through or contemplated in calm moments over many days. This is when people make plans, this is when behavior changes. Finally, we also know that denial of something like HIV diminishes when there are acceptable solutions to the threat. And PrEP, we believe, offers an acceptable solution to the threat of HIV for many people who would otherwise deny the problem entirely. Participation in PrEP programs also provides access to clinic services and a cohort of people all thinking about HIV and doing something about it. So what about PrEP interfering with treatment? Well, I think we have to it remains to be seen whether this is really a problem or not. I would point out that there's several ways that PrEP could enable treatment programs. First, by being an effective prevention agent, it decreases the burden on HIV treatment programs. It will also motivate HIV testing and by providing benefits to people hoping that they're still uninfected. It also will allow seropositives to be identified and linked into care and more timely identification of acute infections. Perhaps as importantly, PrEP will increase familiarity with antiretroviral therapy, allowing a diversity of providers to serve a diversity of people. And uninfected people may become aware of therapy in HIV through their friends taking PrEP, and the whole thing may destigmatize the drugs and the infection. So I just wanted to finish, and I think I need to finish. Is there any evidence that PrEP could alter the course of incubating HIV infection? I just want to leave you with a couple of speculations. The evidence that PEP or PrEP could abort infection before systemic spread is indirect, for sure, but it includes the following, that PEP is effective even if started 72 hours after viral exposure in non-human primates, and yet the first rounds of replication on a cellular level, perhaps not on a tissue level, are completed within hours. So we believe that, that limited infection in the mucosa may be substantially altered. Its course may be substantially altered if antiretrovirals can be started in 72 hours. In fact, we can show that reproducibly in non-human primates. We also have evidence that there are fewer baseline acute infections detected in the active arms of PrEP trials compared with placebo, and I'll show you that data, suggesting that some of the acute infections that otherwise would have led to seroconversion did not lead to seroconversion if high doses of PrEP could be started within days of exposure. There are some experience that post-treatment controllers can occur in 5 to 15% of people who start therapy in acute infection. These may be examples of what are being called functional cures or conversion to controller status by early antiretroviral therapy. And of course, there's the possibility of the cured infant, which I'll talk about briefly. So what is the imbalance that I was talking about in our PrEP studies? We compared the Caprice-04 study, which is a vaginal gel using tenofovir in South African women with Iprex, and we found that in both studies there were many more acute infections detected at enrollment in the placebo arm than in the active arm. For Caprice-04, there was only 1 acute infection in the active arm versus 9 in the placebo arm, and for Iprex it was 2 in the active arm and 8 in the placebo arm. These are statistically significant imbalances at baseline. When combined, it's highly statistically significant. The hypothesis that we think should be explored is that some of the RNA positive, antibody negative baseline infections never manifested as seroconversions when the concentrations of drug were achieved at very high levels in a timely fashion in Caprice-04 and Iprex. And then there's the functional HIV cure after a very early antiretroviral therapy in an infected infant. This is new information presented at the CROI meeting by Dr. Curso et al. Based on a clinical case managed by Hannah Gay and worked up by Catherine Lazuriaga. This infant was identified to be HIV infected within 30 hours of birth. The viral load was substantial at 19,000. They started antiretroviral therapy at that time, and the viral decay in the infant decreased in the typical biphasic manner. At 18 months, the child was lost to follow-up, and we here stopped taking antiretroviral therapy, returned to follow-up with undetectable viral load, either in the plasma or the cells, except possibly a very low signal in the cells using PCR-based assays of large numbers of cells. So this case has raised the possibility that very, very early infection within 2 days of birth might be substantially altered by early and consistent use of antiretroviral therapy. Additional cases like this should be feasible to observe, and we will see if this kind of pattern is confirmed and whether it's the norm or the exception. So just to finish, I'd like to summarize PrEP program risks and benefits. The risks, which are all published, I didn't go over in detail, is that there are some side effects that occur mainly in the first 4 weeks, typically in no more than 1 in 10 PrEP users. There's less average weight gain, mainly in the first 12 weeks. There's an average 1% bone mineral density loss, but no increase in low bone mineral density. Essentially, the bone mineral density loss is mainly observed in people who start off with high bone mineral density. There is FTC resistance, but it so far has only occurred in people starting PrEP with pre-existing infection, which can be detected either by screening for symptoms or RNA testing. The benefits include decreased HIV infection rates, and that benefit is substantial if used daily. There's increased HIV testing and counseling, timely identification of acute infections, decreased partner numbers, more condom use, universal HPV vaccination, routine STI screening, antiretroviral treatment and linkage to care for those found to be positive, and it also enabled structural interventions and engaged communities in prevention. So on many fronts, there were benefits. So I'd like to thank the many collaborators, including Esper, who ran one of the best sites in the IPREX study here in Sao Paulo, and his team. But the work was really made possible by the 2,499 participants and their communities who believed that research could improve their lives. Thank you.
Bob, yeah, great talk, and of course I'm convinced of the benefits and so on. Could you speculate for a minute or so about the future of IPREX and how to conduct a trial, though, in the populations that are really in most need of those benefits?
So, I think that really doing effective education around why placebos are used are essential. And if you're not convinced that your study participants really understand why a placebo has to be used in that study at that time, then they shouldn't be enrolled. I think that we need to take the advantage of having experience with trials in places like Brazil, South Africa, and Thailand to really educate people about how their behavior impacts the interpretation of the trial. Here speaking in Brazil, I think the Brazilians do have part of a solution here. We use, in order to assure high levels of retention in these studies, we do use incentives. There's mugs, there's coats, there's little bumper stickers, there's all kinds of merchandising, but we would call it swag in English, that we give to people, and it's really valuable to them. They love it. Unfortunately, that incentivizes returning for your visit, but it does nothing to incentivize actual use. And so I think that in our efforts to try to assure compliance with the protocol, we've sort of de-incentivized actual use. So I think we have to be careful about incentives. The Brazilian regulations require that people be very careful about incentives and limit the use of swag to encourage. And we see the impact. The Brazilian sites had higher levels of drug exposure than we saw in other countries where merchandising is freely given. Mm-hmm. Hi, Rafiq.
Were there any immunological insights from people who received the drug, to just confirm that they were exposed to the virus and they mounted any kind of response to something that would parallel those people who received the drug that were potentially exposed to the virus as compared to exposed uninfected subjects?
That's an important hypothesis. Esper and Douglas Nixon and I have been actively pursuing the idea that being exposed to antigen during protection by PrEP could lead to immune responses. It did not. What we did find, or what they found, was that certain CTL epitopes, when recognized in uninfected people, regardless of whether they were taking PrEP or not, were highly protective against subsequent acquisition of HIV. So in the context of the IPREX study, we did identify, or they identified, epitopes that appeared to be highly correlated with protection. In fact, more highly correlated than PrEP itself. One of them was 70%, reduced HIV risk by 70%. However, these are correlates of protection. They could be confounded by biology and including expression of different antigens. But one thing that seems clear is it had nothing to do with PrEP. That phenomena was equally evident in the placebo arm and the active arm of the study.
And another question. So were there any biological correlate of failure? Of
biological
protection by PrEP, like inflammation or?
No, the 100% of the variance in PrEP activity was explained by the drug levels. So that's biology, but it's pretty simple.
Other questions? Just one question. New agents in PrEP.
Yes, new classes of drugs are being evaluated, including long-acting non-nucleoside reverse transcriptase inhibitors are being evaluated in both injectable and topical and vaginal ring kinds of formations. Entry inhibitors are also an attractive candidate for PrEP, given the importance of CCR5 interactions for establishing beachhead infections. Raltegravir is also of interest as a possible PrEP agent because it is so well tolerated and could conceivably be formulated in very long-acting forms. So there are things in the pipeline. I chose to focus on what we know works because I think it is underutilized, but research on alternative classes of drugs is clearly important.